Recording in progress.
Yeah.
Yes, warm welcome, everybody. Thanks for joining us, for sacrificing your Saturday. We're not going to take the whole day, just probably half the day, learning about X-rays. I hope you and the family are well, and let's get started. So what I'm going to do is I just put my video on to say hello and how are you. And what I'm going to do is I'm going to switch my video off because I don't want the video to impinge on your screen. Uh, and then, when we're taking questions at the end of each session, maybe I can see you again. So that's me saying goodbye. And yeah, let's get started with this one. Chest X-ray. Today is the 20th of September. It's the day the Lord has made. We shall rejoice and be glad in it for X-rays. Okay, so the goal of the series is to take people who literally don't know much about chest X-rays, but I'm sure everybody here probably has some fundamental knowledge of X-rays, and teach you everything you need to know while taking care of your patients, regardless of your specific healthcare profession, with one exception, that being a radiologist. So if you do happen to be a future radiologist sitting here, I think these videos will still provide a very good early foundation, but I suspect you probably want to check down something a bit more robust. Okay, so this is what we're going to cover, guys. We have how many? 10 lessons? 10 lessons? No, 9 lessons, and then we get into the quiz. So the first one is introduction and physics. Now here we're going to cover the fundamentals of how an X-ray is taken and the physics involved. Like we said in the info session, don't let the word physics scare you away. It's really basic and includes some very pretty pictures. Then we got systematic approach and anatomy, in which we're going to introduce you to a systematic approach to chest X-ray interpretation and demonstrate how X-ray shadows relate to normal chest anatomy. Then we're going to take you through assessment of technical quality. Here we're going to go through how to assess the technical quality of a film. And then lessons 4 through 8 are going to cover each of a subset of chest pathology that can be assessed with the X-ray. And we're going to look at plenty of examples of common abnormalities in each of these domains. And lesson 9 is going to discuss how to assess the placement of lines, tubes, as well as how to identify devices and consequences of prior surgeries with a focus on artificial heart valves. And then lastly, we got the self-assessment where unknown chest X-rays are displayed alongside a clinical vignette, and then we will review these. Okay, just to consolidate all the information that we cover. So by the end of these 10 lessons, you should be able to confidently identify the overwhelming majority of abnormalities that we have on a conventional chest X-ray. Okay, so we have 15 people with us. Can you give me a thumbs up, guys, if you are ready to go? Let's see those thumbs. So I know that you guys can hear my voice and see my slides and everything is on board. Yeah, we love to see that. Okay, so, and of course, I got my jokes along the way. So, people think that radiology is easy, but it's not all black and white. There's a lot of gray area, as you can see, gray in the X-ray. Okay, let's get started, guys. Learning objectives of our first lesson. So our first lesson is looking at introduction and physics. So to be familiar with the basic physics and method of obtaining chest X-rays, and then to be familiar with the basic chest X-ray views, that's the posterior anterior, PA, lateral, or the so-called AP anterior posterior. Now, along with the ECG, the chest X-ray is one of the most common diagnostic tests in medicine that does not involve drawing blood. Now, there are many indications for a chest X-ray. Why would you probably want to consider doing a chest X-ray? Well, let's look at the indications. First up, evaluation of symptoms. Your patient comes in with shortness of breath, with chest pain, cough, hemoptysis, fever, unexplained weight loss. Okay, or maybe you just want to evaluate some physical signs, like you saw the patient is hypoxemic, they're in type 1 or type 2 respiratory failure, or they have maybe crepitations, bronchial breathing on the examination of the chest. And maybe you put in a central line or a nasogastric tube or an endotracheal tube, and you want to check for correct placement of your tube. Maybe you want to screen for a complication, like a pneumothorax after you do a lung biopsy or after you put in a central line or a pacemaker. And then lastly, evaluation of suspected pacemaker lead fracture, another specific indication, but we're going to be looking at some examples of this in lesson number 9. Now, there are a few indications not listed here. For example, routine chest X-rays before surgery. In the overwhelming majority of patients, these are of no benefit and should actually be avoided. Also inappropriate are routine screening chest X-rays for lung cancer in smokers. Although these may be of benefit in screening, probably chest CT is a better option, but that's a discussion for another day. Okay, so let's go, guys. How do chest X-rays work? Well, we need a source of the X-rays, which are themselves a source of electromagnetic radiation. X-rays are carried by these little particles called photons, just like visible light, but has higher frequencies and thus higher energies, so they penetrate tissue much better. Now, unfortunately, these very high energy photons can cause DNA damage, leading to cancer, which is why X-ray exposure should generally be limited. To detect the presence of X-rays, we need something called, appropriately enough, a detector. There's our detector right here. Now, for the first 100 years of X-rays in medicine, the detector was just a photographic plate or film, and I will add a sheet here. So there's my sheet right here of unexposed X-ray film. Now, however, most hospitals have replaced these with digital detectors, which allow for real-time viewing, as well as improved post-exposure digital manipulation. Finally, of course, we will need our beloved patients to stand in between the source and the detector. Now, the patient here, if you notice, is in the typical position for a chest X-ray. She's facing away from the source, hands on her hip, and chest against the detector. Now, the reason to put your hands on your hips, not because she's upset, because a lot of people put the hands on the hips when they're upset, but the reason she's putting her hands on the hips is essentially to keep the arms from obscuring the view of the thorax. The reason she is standing in a way that intuitively is backwards will be discussed in lesson 5. So now we have our source, we have our detector, we have our patient. So we will turn on our X-ray for a very brief predetermined period of time. And X-rays, which are high energy photons, will shoot out of the energy source. Some will pass right through the patient, some will be absorbed by the interposed organs and tissues, and some will be scattered. Now, for the purpose of examining the X-ray film, actually, the pattern of photons that are blocked is what is of interest to us, because this creates the shadows of the internal organs. All righty, enough about that. So what are the factors that determine how many photons pass through a particular spot on a patient in order to reach the detector? In other words, what are the factors which determine shadow brightness on an X-ray? Well, there are essentially 3 that we talk about. First up is something called density, right? The density of the interposed tissue. Technically, this depends not just on the literal density, which, as you guys remember from high school, is mass per unit volume, but also independently on the atomic mass of the particles of interposed tissue. Let me show you guys some examples. So here is our table, all right? And on it, I have placed an empty glass jar. Now, what does the jar contain? It contains air. On the far side of the jar is a photographic film. Notice that it starts off white, and then we bring our X-ray source in. We fire some X-rays at the jar as shown, which of course are not in the visible light spectrum as this illustration suggests. And the X-rays are traveling across the table. The ones that pass around the jar or through the jar interact with the film. And here is what is left. Okay, now any part of the film which many X-rays have struck turns black. Parts of the film where no X-rays have struck have remained white, and the parts of film with a modest amount of X-rays struck are various shades of gray. Not 50 shades of gray, just various shades of gray. Now, since air has a very, very low density, X-rays easily pass through the jar, and thus the jar appears empty on the film. Not the lid, though. This lid is a metal lid which has blocked nearly all the X-rays and has left a very sharply demarcated rectangular patch of white on the exposed film. Righty. Now here are some other examples. Let's now take a jar of water, H2O, and do exactly the same thing. Expose it briefly to X-rays, which also exposes the film behind it. In this case, water is denser than air, so it blocks more X-rays than air, and so the jar's contents appear gray on the film. It is important to realize that even if the fluid in the jar is completely 100% transparent, as is water, it will still block X-rays and therefore still appear gray. Now, the fraction of X-rays a substance blocks has absolutely nothing to do with its color or degree of translucency within the visible light spectrum. But now for a more interesting test subject, what happens when the X-rays, so this is basically the image that is formed, right? What about a skull? What happens when the X-rays strike the skull? You can see that the resulting image is lighter than the jar of water, but not pure white like the image which is formed from the jar's metal cap. Okay, so that was just to introduce the concept of density. So there we go. That's what's left. Okay. So in summary, guys, there is a spectrum of radio densities into which different materials fall. Those that allow X-rays through are called radiolucent and appear black or near black on the X-ray. Those that block most X-rays are termed radio opaque and appear white. Now, for medical X-rays, there are essentially four classes of material that we speak about. There's air, which is the most radiolucent, and next is fluid and soft tissue. Then is bone, and finally metal. Okay, is everybody good with density? Can you guys give me some indication, maybe a thumbs up or high five or something? Or a heart? A heart is good. Yebo. Awesome, awesome, guys. So that was density, right? So the next factor which determines shadow brightness is the thickness of the structure being X-rayed. Now, if we take a single relatively thin glass of water and expose it to X-rays, most will pass through, resulting in a very dark image on the film. If instead of one glass of water, we lined up two glasses in a row and shoot X-rays through both, twice as many will be blocked. The resulting image will therefore be more gray because the specific part of the film corresponding to the shadow of the glasses has been relatively less exposed. Finally, if we shoot X-rays through three glasses of water, the image of glass will be brighter still. In summary, the thicker the structure, the brighter it will appear. The thicker the structure, the brighter it will appear. Now, the third and last factor we're going to be discussing is called the duration of exposure. How long is the exposure? So for the X-ray interpreter, this factor is only relevant when trying to understand technical error in image acquisition. So imagine now if we have two glasses of water again, and I'm going to leave these X-rays on for a very brief period. And during that brief amount of time or short exposure, few X-rays have an opportunity to pass through the water, so the film where the glass's shadow has passed is relatively underexposed and thus is relatively bright, as you guys can see. Now, if I used the same two glasses of water, but this time there's medium exposure, then the film behind the glass will receive more X-rays and the glass will therefore appear a little bit darker. I'm sure you guys can appreciate that. I hope it projects appropriately. Finally, if I use long exposure, even though the glasses of water are in the way, there is enough time for many X-rays to pass through the glasses so that it appears fairly dark on film. So can you see the difference, right? It's a short exposure, medium and long-term exposure. It's very bright with short exposure and it's darker, much darker with long exposure. So in summary of this, we said that short exposures leads to images being too bright and long exposures lead to images being too dark. Now, this is the opposite of what most people usually expect because intuitively we believe that all film starts off black and turns white after exposure to light. But remember, X-rays are the opposite. Let's now, Shane, return to our patient. She's been waiting so patiently. Thank you, patient. You're very patient for us today. Return to the patient who has been waiting patiently for us in the radiology department, and let's fire some X-rays at her. Some pass through, some get absorbed, a few even get scattered around the room, and the result is an image that is formed on the photographic film of the shadows cast by the various structures in this patient's chest. And here is that exact result. Now, from the pattern of white, black, and gray, we can infer certain things about this chest structure. For one, this area here, because it is generally dark, must correspond to what? To air, an air-filled structure, and that will probably represent the lung, right? This area here is kind of moderately gray in brightness, and it must correspond to a structure composed of either fluid or soft tissue. In this case, that is our beloved heart. And since the layout of the human body is amazingly consistent from person to person, each major line and shape on this X-ray corresponds with a known and identifiable anatomical part. We will then, obviously, in the next lesson, we will review these different anatomical parts. But before then, here are a few practical things to put out first. It may have happened so fast that you didn't Notice it. But when I removed the film from the detector stand, it flipped around horizontally. The consequence of this is that the left side of the film, as we are looking at it, actually corresponds to the right side of the patient's heart and vice versa. So when you look at an X-ray head on, this is the patient's right side and this is the patient's left side. This puts the X-ray in the same orientation as if we were standing literally in front of this patient, looking directly at him or her. Now, if that seems a little bit weird right now, it will soon become intuitive after examining a dozen or so chest X-ray examples. Now, the second practical thing, guys, I want to mention is the idea of what we call chest X-ray views. Now, in radiology, the term view refers to the orientation of the person relative to the beam of X-rays. So at this point, there are three views that I want you guys to know. The first view is the most important and the one you have already been shown. It is called the posterior anterior view, or P to the A. P to the A, posterior anterior view, meaning the X-rays enter the body squarely in the back and exit it squarely at the front. In most cases, the PA view will be automatically accompanied by the lateral view. Now, as the term implies, the lateral view is a two-dimensional projection of the patient's internal structures as viewed from the side. Okay. Now, the PA view has to be distinguished from another situation common in the hospital where the patient may be unable to stand due to weakness. Okay, there's many reasons why the patient can't stand. Maybe they're weak, maybe they're confused, maybe they just underwent surgery, maybe they've got invasive tubes, maybe this is the ICU. Okay, so in this circumstance, when the patient is in a hospital bed, a portable X-ray source will be wheeled into the patient's room. An X-ray will then be placed into a metal tray and slid behind the patient's back. So there's the little metal tray behind the patient's back, and X-rays will then pass through from front to back. Normally, it's back to front. Now it's front to back. This is what we call the anterior-posterior view. Some people call it the bedside unit, or the BSU. Okay. Now, I just want to point out that EP films are inferior in quality as compared to the PA films for a number of reasons, which we will discuss in lesson 3 and again in lesson 5. But for now, this was lesson 1 on chest X-ray anatomy and physics of chest X-ray acquisition. Brother Mawela, this was the first lesson. I'm not sure if anybody has any questions, if anybody has any comments, anything on the chat group. Okay, there's nothing new on the
Recording
chat group.
stopped.
Let's see. Q&A, Q&A. Anything on the Q&A?
Are you good, colleagues?